Welcome, everybody, to the SurgeonMasters Podcast. I have with me our guest from a couple episodes on our mini podcast. I have Dr. Jim Naples, a Harvard ENT at Harvard Beth Israel Deaconess Medical Center. And also with us is clinical and sports psychologist Jim Doorley, who does psychological services for the United States Olympic and Paralympic Committee and is a research fellow in integrative medicine at Harvard Medical School. Welcome, Jim and Jim.
Thank you.
Pleasure to be here.
So each of you shared a teaser, a little bit of your knowledge in our mini podcasts. One that we talked about as being surgical mindset and other being performance mindset. And obviously, and maybe not obviously, I think all of us agree that this is an overlap and why the three of us are so psyched and interested about the topic. So if you look at this as a surgeon, and in our careers, we spend a tremendous amount of time looking at technical skills and clinical knowledge. And what I understand from both of your mini podcasts is that you feel that we've talked too little about the mindset aspect of things. So why don't you give me your initial take on this as a surgeon?
Yeah, I think that's pretty spot on in how I feel about the topic and why Jim D and I got together, in that I reflected on this for many, many years over the course of the end of my training and into my practice. And in reflecting on what it is that I struggled with during my training, and I think what a lot of people deal with as they come out as a surgeon, most of the factors that lead to surgery being difficult rarely have anything to do with the technical aspects of it. And so my reflection on my experience, that's really what kind of got me curious and thinking about this over the years, and ultimately how I got in touch with Jim in trying to see how we can address that.
Jim D, when you first met or had your first few meetings with Jim Naples, tell me a little bit about how some of that conversation evolved and why you got excited to be having the conversation with him.
Yeah, I do remember some of those initial meetings, and it was exciting because, it's pretty rare to have a non-psychologist, never mind a surgeon, approach you and say, hey, I'm interested in learning about what you're doing. I think this is cool. I think this applies to my profession and my teaching. I think as sport or performance psychologists, we're often stuck kind of trying to sell our work, even though I don't like using that word, but trying to pitch to even the organizations who hired us, like, hey, this is valuable. I promise, like, you can use me. I have stuff to offer. And to have it really be the opposite of someone saying, hey, I proactively want to know more about what you do. And I want to apply it in this novel way. That was pretty cool. And I could sort of tell that we were going to work well together from the early meetings.
We're definitely the odd couple in a lot of ways, in that I don't know many surgeons that spend their time thinking about psychologists to connect with. So
yeah, in the time now, fast forward to a lot of things that you guys have been doing and moving forward. So tell us, some of the different things, topics or tools within the space of surgeon mindset, performance mindset that you think are really key for our listeners to tap into.
We've been talking about a number of different kind of performance psych or mental topics that we want to introduce to trainees. And we're trying to build this out the right way, which kind of involves doing a lot of exploration of the literature, of course, the core kind of sports psychology works that have been done, but also some of the work that's been done in surgery, and focusing on not just what are the kind of core sports psychology skills that you see all the time in the research, cognitive restructuring, self-talk, mindfulness, like how can we actually tailor these skills well to the problems and challenges that the surgeon or the surgery trainee encounters? That's where I think we both see a gap and an area for improvement. We are collecting qualitative feedback from the trainees that we're working with to try to better understand what they're liking about our presentations and didactic seminars that we've done. And we're wanting to do more of that so we can really start to build out a curriculum that is informed by their preferences and works for them. And that's just on the curriculum side. We're trying to, in part, to influence our own thinking on the topic, write more on this,
Excellent. And Jim, and if you want to add to, please go ahead and chime in.
Yeah, no, I think it's creating a curriculum around this, for me, cannot be done without Jim. And the reason I'm so excited about this is I have all of these experiences where I see things happening that are strictly mental hurdles for my trainee surgeons. And Jim has all the vocabulary to help me to understand it. And so that's really what we're excited about is I can simplify the emotion and the feeling that a resident has when they're learning, or my students. But it's really nice to complement that with here's the science to back up why. And then we put our heads together to say, well, what's the best way to deliver that message and execute that? And so it really is, it's just an incredible collaboration and team to be a part of to make that happen.
And even though your curriculum is expanding and growing, what are some of your early experiments or successes in sort of providing this knowledge and information?
Yeah, we've been putting some stuff together, and we're working on something right now that I think we're both excited about, which is kind of bouncing back from mistakes. And I actually haven't seen this, I could be wrong, but in existing kind of works, sports psychology approaches to surgery, it's a crucial topic, and it has been studied quite a bit. Jim and I were both kind of looking into the literature on second victims, I believe they call it, about, physicians and surgeons who make a mistake or are involved in a serious patient adverse event. And how can we think about supporting the physician or trainees who were involved in that mistake, maybe even caused it, in addition to, of course, the patient, which is the primary goal, the primary person we want to support. So we were thinking how there's been a lot of good work done in that area, but there's probably more we can do in using a sport or performance psychology lens, because we want to obviously emotionally support that person who's made the mistake, which is already kind of a radical shift in how people might think. But we want to help people bounce back, whether it's from a catastrophic mistake or just a smaller mistake. There's bleeding that was unanticipated. How can we mentally shift ourselves? In sport, we talk a lot about getting to the next play. Can't remember if I mentioned next play speed last time, but that's something that I like to talk about, that other sports psychologists talk about. That's one topic. There's others as well we could get into.
And we don't even have to go fully in depth, but what you're highlighting and my knowledge of adverse events is what people don't understand is we sometimes talk about the tip of the iceberg, which is the most drastic mistake or outcomes and bouncing back from that. But that often is happening after surgery. What you're also highlighting is you make one little mistake in surgery, and it's not even, who knows the severity of it, right? Like in some surgeries, it could be getting into bleeding, or in other surgeries, it could be a little bit of a bigger mistake. But in your mind, any mistake under the pressure of a faculty member next to you might feel like a huge mistake, even if it's not. So like what you're highlighting, it's a skill to learn at various levels of severity. Like this mistake puts you out of the event, or this mistake, you're still in it. And if you don't rebound from the missed shot or the missed save or the missed whatever, you're going to get scored on again.
Yeah, that's exactly right. And I sometimes will talk with athletes about the idea of, performance is broken up into a series of moments, really. And we want to be as present as we can be in each of those moments. And what happens when a mistake happens, right? Moments go by where we aren't present, where we're kind of stuck on what happened. And meanwhile, we're missing an opportunity to go and kind of win the next moment. So if you think about it that way, with greater granularity, there can be one moment or a couple moments that were a mistake, but how much can you maximize the moments to come, right? And really be present and shift yourself as quickly as possible, because that is a win in itself.
And Jim Naples, what have you noticed in either your trainees or in your own experience as far as just the nuance of some of the skills of rebounding from a mistake?
Yeah, I was going to comment on this. There's two types of rebounding to me in surgery, the immediate and then the long term. And I think surgery and medicine in general does a pretty decent job of trying to address that long term. We have M&M conferences, morbidity, mortality conferences, that happen often at some distance afterwards, it's a good way to debrief in some ways, get lots of opinions on things. But more relevant to what I see is the immediate bounce back struggle of like, we finish a case at noon At 12:30, we have another case to go. There's some similarities, and what people will often do is carry that first case with them. So I'm a big proponent of telling our learners, each case is an independent event. A bad first case or a struggle in the first case does not mean you're going to struggle in the second one. It's a flip of a coin. So don't carry that last one with you. They're separate and independent events. So I use that as kind of my analogy to say, don't carry it with you. Let's bounce back and we'll debrief at the end of the day to kind of review some of this stuff. But forget it for now and move on so we can make progress with the next one.
And just as an overview, we may have additional discussions about this and do them as separate podcasts, but a little bit to just expand it beyond our mini podcasts where we maybe touched on just one or two issues here. Like I'm curious as to a small list. And let me just share some thoughts that I have on mental fitness in the operating room. So we're talking a little bit about rebounding or recovering from mistakes. I think there's even like a preoperative one of the skill of visualization of what you're going to do. So it's sort of a pre-performance mental exercise. I think of how you manage distractions. I mean, I think people are tremendously shocked and somewhat entertained by the amount of distractions that often a surgeon has in the operating room. They might be operating while they're on call. They're getting phone calls and messages from the floor or the emergency room. People are coming in and out of the room planning like the next case, or anesthesia might be talking about needing help in another room. Like there's a huge amount of distractions. And so distractions, and I could probably come up with more, but I'm curious what others you have discovered as being kind of in this curriculum or just things that people should learn.
Yeah, I think one of the things that makes me think of it, I alluded to this last time, where I don't listen to music in the OR. It's just one extra stimuli that I don't like to have to think about. But everyone's different in that. But I think there's lots of really fascinating data now with the OR black boxes out there. I don't know if you've heard anything about that, but lots of information coming from that supporting what you're saying is that it's a busy, busy environment. And I tell our residents all the time, the sooner you learn to focus on what needs to be done and not all the extra stuff, the easier this process is going to be. And so, again, we talked about this too, being very active and explicit about tuning things out. This whole mental process, it's a very active process that requires active tuning out and active focus. It doesn't just happen. The OR black box data is really fascinating to me in that regard.
Yeah, and I can get into some other things that we're thinking about with this curriculum, two other skills like the ones you listed. One area would be, I think, emotion regulation and how emotions impact decision making. Because as a novice surgeon or trainee, I'm not a surgeon myself, but I think from learning and talking with Jim, I can just imagine that the emotion, the anxiety, of course, the nerves, everything is heightened in those earlier experiences. We know from a lot of the psychological literature that emotion is impacting our decision making. Regardless of how intelligent or rational we are, emotions are going to make an impact. So how can we be aware of our emotional state and regulate our emotions in such a way that gives us a little bit of space, a little bit of breathing room to make a clear decision? And of course, a relatively quick decision, because there are quick decisions that are required.
Yeah, it's a great topic. And just to tease a little bit, other things in this realm of what people would learn in a curriculum like this is that in old school surgical training, the idea was to depersonalize it, right? To separate your emotion from your thinking. And that's a learned, trained skill. The irony is that same skill is the definition of one of the components of burnout. When you depersonalize, you're burned out. And so you're having to balance this. If you do it too much, then you're not really doing surgery or medicine for the reason that you wanted to, because you wanted to help other human beings. And if you do it too little, you're putting yourself at risk of experiencing all the emotion and having it potentially affect decisions. So it's a really interesting concept to follow the studies and research and then do more of those to see what actually affects performance.
Yeah, that's right. And it's quite a difficult burden to place on a trainee, saying all the emotions that you're surely feeling right now, just compartmentalize those, set those aside, that this isn't the place for it. That's how you're going to perform well. That's not really possible to do. There are going to be emotions there. I think the way to empower surgeons and trainees, it's similar to the way I would empower athletes, which is saying, hey, if you learn the right skills, you can perform well and do your job well, regardless of how you're feeling. And you can't even really control how you're feeling. Emotions are going to come up. The emergence of an emotion is largely an automatic and uncontrollable response. It's really about how we then respond to that emotion, right? What we do next.
Yeah, I was going to comment there. Two things that I try to do with my learners in those situations is sometimes you do have to put that emotion aside to accomplish the task. That's just the reality of it. But to me, the immediate debrief, when that patient's waking up from anesthesia or once you get them to the recovery room, that's when you dive in to say, hey, what were you feeling? How did that influence how you're thinking? And that's when you can easily dive into those emotions, at least to kind of temporize that and normalize that experience. And then the second thing that I like to do there too, and Jim Doorley and I have talked a lot about this, is exactly that, normalizing that experience. And so what I do is the first thing I do a couple months into our trainees residency program is I write them a letter of a large number of mistakes that I've made during my training to open that door to say, this is a very normal experience. Everything that you have felt at some time is something that many of us deal with. It's okay. If you need to talk about it, I'm here. This is my way of opening that door. And so I kind of preemptively open that emotional door to say, here it is, and see how trainees take that.
This is great conversation because the point that you're making is that in the curriculum, you help people understand that this is skills that they need to learn. And then you're doing that live and kind of recognizing that in your curriculum, you're tailoring it to the actual surgeon experience. There may be times that it might be compartmentalizing or it might be putting a pause on it, but having that go on indefinitely can't be the right way because in all the psychological literature, that's not a healthy technique. Right. Yeah. And so when can you integrate it at an earlier phase? And is that immediately at the end of the case? And there's a component to normalizing it. So this is fantastic stuff that people should be learning and recognizing. And it's stuff that you guys are pointing out that it can be taught.
Yeah. And I think you mentioned the piece about burnout, that coping or managing emotion in this way of depersonalization can lead to burnout. It's even kind of a symptom of burnout. And we may have gotten into this last time a little bit, but these are things that at least I hope to address among the trainees that we're working with, this stress and burnout epidemic, although people are also burnt out on burnout. And there's literature on that of like, can we stop talking about burnout? Like, don't make me go to another sort of training or course where we talk about burnout and well-being in these kind of superficial ways. So our hope is that talking about mental performance and emotional resilience are ways that really are getting at the same end goal, but they're a little bit more engaging. It's a little bit more fresh than what trainees are used to.
We've been talking fairly serious about these topics, but I want to bring a little bit of lightness because we did mention it in the podcast release that Jim Naples mentioned that he doesn't like the distraction of the music. And I wanted to tease him a little bit on this because it sounds like you guys got a lot of backlash when you've talked about that in the past.
My ABCs of music in the OR are anything but country. You can listen to anything you want. If you really have to listen, anything but country. And in jest, I say that because it just doesn't work for me. I don't actually mind it, and I won't tell people to turn it off. But if I'm at a point where I need to focus, it doesn't work for me. But certainly I have a colleague who hates being in the OR with me because he can't function without it. And so I know Jim Doorley was mentioning before about how the cognitive load and the amount of stimuli in the room. When you get to a certain point in surgery, the cognitive load as an experienced surgeon really of doing a certain task isn't often high enough where a little music is going to interfere. It's just something that I've made practice because a lot of the times there's communication among the trainees and team members that I've found music just helps eliminate one extra thing. I do like music, just,
Yeah, I think the point you made is that these are things that may depend upon the surgeon. They also may depend upon the team. And so if there was two surgeons in there, or if there's others in the team that might be distracted by that music, there may be a necessary compromise, because you want everybody performing at their best, and music absolutely can be a distraction, and it can be cognitive overload. If you're just going to assume that it's not, or that it doesn't affect you, maybe you ought to be willing to experiment. Maybe you ought to be willing to recognize there are times where the music is beneficial and kind of might cut out some of the other distractions of beeps and other things that might distract you. Or it might be a time where it isn't appropriate, and you're going to actually up your performance by putting a pause on it or changing it or something, right?
Yeah. Most surgeons are probably afraid of their own thoughts, and so maybe they don't like to listen to them.
That's definitely
Could be possible. What do you think about that, Jim Doorley?
For sure. I think we're all to some extent afraid of our own thoughts. We have difficulties doing nothing and having no stimuli, right? That's where we go for our phones and everything else. But yeah, it's an interesting point about the music. And I think about what it feels like to be experiencing in a moment of acute distress, let's say doing anything but doing surgery, and to be having like Jason Aldean or someone blasting in the background too at the same time. That's not going to make the situation better. I think the kind of music even does matter, right? Like I could imagine, of course, like a classical type of music having a different emotional effect than other types. Yeah, that's one thing I think about. Those moments of high stress or something unexpected happens. What do you do then? You probably want to reduce all unnecessary stimuli to really be able to zone in. And I think some athletes find that too when they're about to hit a really challenging part in their workout, a sprint or like all out exertion. It's a different kind of exertion, arguably, the physical. It's all kind of zapping our resources in different ways. And music is just another thing. I too love music. I play music. So this is not a case against music. I think Jim has made that clear. One thing that I think is really important that is sort of like in the introduction to our curriculum is thinking about surgeons and surgeons thinking about themselves as high performers, not unlike a high performing athlete. I think that's important to set the stage for the trainees, basically saying even college athletes in Division I institutions are getting all kinds of resources to facilitate their success. They're getting athletic trainers, physical therapists, nutritionists, they're sports scientists working with teams, they're getting academic tutors. They have these multi-million-dollar buildings with every kind of comfort and amenity imaginable. And it's all to just give them those extra 1, 2, 3, 4% gains and to make them honestly happier at their job. And why aren't we doing this really at all in surgery? You know, it seems that sometimes things are designed to be as uncomfortable as possible. And for sure, it's not going to always be a comfortable process, learning and performing surgery and working those hours. But why can't we make it 5% easier? And not just, it's not really about being easier, but giving people the tools for success. And that including thinking about, you know, I guess self-care is kind of a part of it, but the learning the mental skills is, of course, the main part. This is something else you can do that you have control over that can augment your success. And it's a mindset, right? If you think about yourself as a high performer, all of a sudden these things sound relevant and important to you. And I'm going to learn them just like other high performers are learning mental skills.
Absolutely. I'll have Jim Naples add to that. But I think the key messages that I'm hearing is we need to recognize that we should be addressing surgery and surgeons in a similar fashion, and that includes the athlete or performer or surgeon as recognizing that these are skills for optimum success. I think there's a ton of knowledge in the sports literature. There are people that are actually physically skilled beyond the level that they make it, and that they usually drop out or don't go to the next level because of these other things. Like they're not taking care of themselves physically, nutrition, et cetera, sleep, all that sort of stuff. And then even mentally to sort of address like, okay, so you're awesome, but what do you do how do you rebound after you aren't awesome, right?
Yeah.
And then the other super key message was, wow, wouldn't it be nice if organizations and hospitals and institutions were actually investing in these gains that they would get out of people that are performing the skills that their patients need?
Mm-hmm.
Yeah, for sure. that to me, I think is something that we've talked a lot about. Medicine, we looked into the history of this a little bit in terms of sports, not a deep dive in the history, but the fact that we're starting this conversation now means we're probably a couple of decades behind where professional sports was. I always remember a couple of baseball players that had the yips. They couldn't throw the ball to first base. Some pitcher for the Cardinals couldn't throw a strike, so they moved into outfield. These concepts of performance psychologists weren't around in the 90s and 2000s for professional sports. Eventually, they caught on and realized, oh, this is valuable. And I think medicine is right at that cusp where baseball was 20 years ago, 30 years ago, of, hey, people are starting to talk about it. And that's where we want to be, kind of at that forefront of starting that conversation of like, well, why aren't we promoting kind of performance enhancement as a thing for people who do pretty high performing stuff? I always joke that our health systems think a surgeon's idea of a good breakfast is like a cold cup of coffee and a donut. And it's just not really the way that it should be. Our hospital thinks that Doctor Appreciation Day or Resident Appreciation Day or, Healthcare Appreciation Day is a free cup of coffee, which is probably cold or something, and it's like, I think there's more to it that we can and should be doing.
Well, I really appreciate both of you having a longer conversation with us. And it sounds like the three of us could go on and on because there's so much that we already know and so much that the two of you are driving to learn more about. So I appreciate you being our guest again with Surgeon Masters.
Thanks a lot for having us.
Yeah, I really appreciate it. Lots of really great conversation to have.
I think, maybe what I'd encourage our listeners to do is to notice some of the things that we brought up, be curious about these things, kind of reach out for more knowledge and information. I suggest that you follow Dr. Jim Naples and Dr. Jim Doorley as the sports psychologist and what they're doing to help educate our next generation of surgeons. And we can probably, in all generations of surgeons, also be learning as well. Thanks for joining us and talk to you soon. Ciao.